who have seen our previous webinars, I'm back and would like to welcome you to one of the series of webinars sponsored by the University of the Philippines Alumni Association of the Metropolitan DC area. I'm Michael San Juan, one of the officers of the organization. Incidentally, I will be your moderator for the day. It is 5:33 p.m., August 5, 2020, Eastern Standard Time. Few house rules. All microphones are muted with the exception of the host, the speaker, and the moderator to prevent any source of feedback. We ask that you reserve your questions at the end of the presentation during the question and answer forum. What to expect during the webinar? There will be a brief introduction of the speaker, a 20-minute presentation, followed by the question and answer. Then we will have a short message from the president of the organization, and lastly, some announcements. Today, I'm pleased to introduce our speaker for the day. Dr. Robert Sunga is an ophthalmologist in the Washington, D.C. area and has more than 30 years of experience in the health and wellness industry. He is an associate professor of the George Washington University Medical Center. After his residency from the University of the Philippines, he was granted a travel grant and scholarship from the German Academy Exchange Service, otherwise known as DAAD, or in the way it's pronounced is Deutscher Akademischer Austausch Dienst, following an intensive language course in the Goethe Institute of Germany. He continued his scholarship at the University Eye Clinic in Heidelberg. He completed a fellowship in ophthalmology at the Wilmer Institute, Johns Hopkins University. Ladies and gentlemen, please help me welcome our speaker, Dr. Robert Sunga. Dr. Sunga, you have the stage.
Okay. Well, good afternoon. Hopefully, is it time for dinner? And almost everyone are elderly or not so elderly. So I decided to give a little talk. It's appropriate for me as an elderly myself. So let me share the screen and then we can start. Okay. So let's start about talk about a little bit of aging of the eye. It's really appropriate for me because I had my cataract surgery a long time ago. So start with the first slide. Okay. So this is the journey of life from infancy to elderly. And by age 65, 1 in 3 may face some visual loss. And there are some potential consequences, and daily activities are curtailed. And like me, I'm missing golf. And some would just be dreaming about the good old days. And especially my wife, missing mahjong and becomes blurred. Then because of loss of eyesight or vision or decrease in vision, in some instances, it's financially devastating. Okay. And this is fairly common because you can see very well, difficulty recognizing people. And the most devastating is inability to drive. Okay. Some persons become depressed, isolated, and because of problems with mobility, then frequent falls and fractures. And loss of independent living, but probably at this time of COVID, a nursing home might not be a good alternative. So at age 45, probably most of you still will have 20/20 vision, but when you reach 75, the average is about 20/40. So what is the minimum requirement for driving? In the district, and in Virginia, and I don't know about Maryland, is 20/40 in the better eye. And as you can see, this lady driving very, very slowly, 5 miles an hour in a 35-mile-an-hour zone. Just about 1% only of the 45 years old guys have their license revoked, but at age 75, about 20%, unfortunately, will not be able to get their license. What is legal blindness? It's defined by the federal government as 2,200 in the better eye. But the only advantage of being legally blind, unfortunately, being legally blind, is you get an extra exemption in your income tax. At age 45, only about 1% are legally blind. At age 75, it reaches about 12%. Okay, so we'll talk about aging and the crystalline lens. So the lens is in a young individual is fairly clear. And as we get older, it becomes yellowish. I don't know if you've seen this painting here in Washington at the National Gallery by, I really don't know how to pronounce, is it Monet? Monet? It might probably be Monet. This is the Japanese, very, very famous painting of a Japanese garden in Givenchy. And when this is in 1899, a few years later, he was developing cataract. As you can see, his paintings are turning a little bit on the yellowish side. So cataracts, if you develop these opacities, the most frequent symptom is glare. And as you've noticed, when we reach the age of 40, for me it's a long time ago, arms become shorter, you need bifocals, there's a loss of accommodation, and we term it as presbyopia. Okay, it's having difficulty reading books and the computer. There's really a big advance now in cataract surgery. A small incision is made, then the capsule of the lens is removed, then the lens is emulsified using ultrasound and is removed by suction. The lens is inserted, the lens is inside the tube. It enters as like a roll, like a taco, but it's in a roll. When it's released, it expands. Surgery now for cataract surgery, probably the average is about 15 to 20 minutes. But during my time, the patient has to be hospitalized for a few days, and most of the time they're in a sandbag. So let's talk about aging in the eye, systemic diseases. We have hypertension, and usually it can involve the retinal vein and some occlusion of the vein. The retina is the only structure in the body that we can see the blood vessels, the veins, and the arteries. This is a blockage of the vein, most of the time for hypertension. About elevated cholesterol, like having plaques, it can block the artery. Like this one, it shows a plaque in one of the arteries called Hohenfels plaque, and it can damage and produce swelling of the area where the artery is blocked. This is very, very common. Dry eyes and arthritis is also common in certain conditions like lupus, sarcoid. rheumatoid arthritis. How about diabetes? The most common complications, cataracts, also glaucoma, and seriously diabetic retinopathy. Let's start with eyelid problems. Okay, yeah, blepharitis or inflammation of the eyelids. What are the symptoms? You have burning, itching, tearing, and a lot of crusting. And the usual cause is a colonization with staphylococcus. They are very, very difficult to treat because they are recurrent and chronic and could be controlled by lid hygiene using warm compresses in a towel on the warm side of the faucet. Put it on the eye, on the lids for about 10 minutes. Then you can use baby shampoo in an applicator to try to remove the crusting. And the advice is to do it before showering. You use baby shampoo because it doesn't sting as much. And before showering, so that when you shower, it washes off the shampoo. And in some instances, antibiotics or in combination of antibiotic and steroid is used. Okay, let's go further with eyelid problems. Entropion. This is the eyelid is turning in, so the eyelashes are touching the conjunctiva and the cornea. It can result from involution of the lid or scarring. It can lead to what we call trichiasis, which is the interning of the eyelashes. And the eyelashes rubbing against the cornea, it can cause corneal abrasions. But it can be treated surgically, like in this case. Okay, this is the result of being surgically repaired. How about the opposite? You've probably seen some of this in the Philippines. Instead of turning in, the eye is turning out. Okay, because the eyelid does not close. So it usually results from involution and scarring, also from cranial pulses. Because the eyelids does not close, the cornea becomes exposed and dry, and most often tears would run down the cheeks. And since the eyelid does not close, sometimes you use lubricants so that the cornea is protected. And it can be surgically repaired, and this is the result in this individual. How about drooping of the eyelids? Ano bang tawag sa Pilipinas? Kirat? I don't know how they call it. I forgot, but they call it kirat, which is the drooping of the eyelid. Okay, we call it ptosis. Again, it could be mechanical or neurological. And if we see someone with drooping of the eyelids, we have to check the muscles, the eye muscles and the pupils, because in some instances, it can be caused by what we call a palsy of the third nerve, drooping of the eyelid, the pupil is dilated, also the eye does not move up. And it's, I don't know if you've heard myasthenia gravis. It's an autoimmune disease. The eyelids droop late in the afternoon or after exercise. And in some instances, it's caused by a tumor of the thymus gland. The gland is located behind the chest bone. What's dermatochalasis? I had them myself. The skin becomes loose, loses elasticity. Okay, these are bugs. We call them bugs. And Medicare pays for repair. The vision is affected. the field of vision is affected. Very, very common, dry eyes is the most common condition affecting the cornea. As we get older, the tear production decreases with age. Then the tears maintain the integrity of the cornea and also lubricates and protects the cornea and the conjunctiva from disease. The natural tears have an oily component produced by glands along the eyelids called meibomian glands. This is the tears and oily tears that becomes diminished as we get older. The symptoms are burning, itching, redness, and scratchiness. And if the cornea is seen under the slit lamp using a blue light, you can see these abrasions on the cornea. And paradoxically, tearing is a symptom of dry eyes. There are two types of tears. One is what we call the reflex tears. These are the tears like when we cry, but these tears are deficient in the oily component of the natural tears. So markedly dry eyes can lead to corneal damage. And we advise patients to use artificial tears several times a day for comfort. And if the patient has to use the drops many times a day, the better drops are the single drops, come like a tube. You remove the top. There's no preservative. So once you put a drop in an eye, then you throw it away. The advantage is there's no preservative. Some of the eye drops without the preservative is the preservative that can cause some irritation in the eye. Okay, certain individuals, okay, a punctal occlusion is done. There are two openings here on the eyelid. These openings lead to the lacrimal sac and lacrimal duct and drains into the inside of the nose. So you'll notice when you cry, you also have a running nose because tears from the eyes go through the canals, through the lacrimal duct to the nose. And then a plug is inserted in the punctum to prevent the tears from flowing into the nose. Okay, several years ago, probably 15, 20 years ago, new immunosuppressives were developed. And the most famous is Restasis. Uses it about twice a day. And the newer one is called Cidra. It reduces the inflammation of the cornea. The main disadvantage of these two eye drops, Medicare does not pay for them. And it will cost about $800 a month. So for most instances, unless the dry eye is severe, most practitioners don't use these drops as the first line of drops to use. Okay. The dreaded macular degeneration, you probably have some relatives with this. Fortunately, hopefully not. This is the most common cause of irreversible visual loss. It's loss of central vision. And what are the risk factors? Advanced age, of course. Family history of macular degeneration, smoking, and cardiovascular disease. And we see in the retina what they call drusen. These are German for pits. And these are lipid and protein waste products in the retina. And there are the two types. One is what we call the hard, small drusen. These are small refractile yellowish spots deep in the retina. Most of the time we just observe them and we don't treat them. And we just observe them first every 6 months, then annually. And most of the time it doesn't lead to macular degeneration. The other type is called the soft type, and they're larger with soft edges and confluent. And this is the type that usually leads to macular degeneration. And in cases of advanced stages, we have the dry type. It's a loss of photoreceptors, which are the rods and cones, as you probably remember in your science class in high school. And then the choriocapillaris, which is the vascular network just outside of the retina. Okay, this is a gradual loss of vision. And then the wet type is the more serious one. There develops such new blood vessels between the retina and the choroid. New blood vessels are, unfortunately, they break so easily and they bleed a lot. Okay, then it causes some edema and can develop a disc-like scar. And this is irreversible, unfortunately. Okay, and it's usually a sudden loss of vision. And if the doctor thinks that you might have some drusen, he gives you a sheet with this grid. And this grid, you're asked to see the center. And the grid, all the lines should be parallel. And if the patient has a macular edema, there's this distortion of the lines. They are not parallel, so they become wavy. It's an indication of macular swelling. So patients with macular degeneration, they develop a central scotoma or a central field loss. Okay, the center becomes blind. Okay, and the lines at the center becomes distorted. As you can see in this case, the lines are not straight anymore. Okay, what tests are done? Like angiography of the heart and the brain, a dye is injected, and photographs of the retina are made when the dye goes to the vessels. This is a case of macular degeneration, which is neovascularization. Okay, and then with this test, the type of treatment can be made. And then in about a few decades ago, a new technology, a scan of the macula. It's like a scan, doing a CAT scan. It takes a cross-section of the retina. This is the choriocapillaris, pigment epithelium, the rods and cones. Okay, and in cases of macular degeneration, there's swelling in the area of the macula. Okay, what are the treatment? What's treatment for IMD? Okay, the aim is to reduce the risk of progression. There's really no treatment to prevent it. It's just hopefully to reduce the progression. About 15 years ago, there was this multi-center, a very, very large multi-center study about, I think, about 10 large eye centers. And the study is called AREDS-2, Age-Related Eye Disease Study. And they found that lutein, xanthine, vitamin C and E, and zinc are needed to reduce the risk of progressions. These are the commercial capsules available. And at Costco, they're much, much cheaper. And green leafy vegetables have these minerals like cabbage, like greens, kale, spinach. And in the Philippines, pechay, mustasa, bochoy, kangkong. And I don't know, probably you can think of others. Okay, so we ask patients which might have beginning macular degeneration to eat a lot of green leafy vegetables. In certain cases of AMD with neovascularization, laser photocoagulation is done to burn these new blood vessels. And also, in the last decade or so, the body produces what we call VEGF, or vascular epithelial growth factor. This stimulates the growth of blood vessels. What the newer drugs have been developed is to prevent the growth of these new blood vessels. And the earliest ones are called Avastin. These are also in cases of tumors. I don't have other tumors, but I know in breast tumors. The tumors, the cancer needs blood. And so the cancer produces new blood vessels. And chemotherapy, one of the chemotherapy is to give an anti-VEGF to prevent the production, the growth of new blood vessels. But these are initially very expensive, cost about $7,000 per injection. And initially it was being given once a month, but they found that, then later on they found that just doing it every other month is good enough. Now some are doing it every 4 months, and the hope is to be able to have some that are just given once a year. Okay, and then diabetic retinopathy. Probably about 40% of diabetics can develop diabetic changes in the retina. Okay, and it's very, very common among the elderly, diabetic elderly, and more common in type 2. Okay, it's macular edema again. These are the exudates and new blood vessels on FA, and this is the fundus camera. This is the OCT with the swelling. Okay, there are two types of diabetic retinopathy. The non-proliferative, you have microaneurysms and also exudates. But once they progressed with producing new blood vessels, we call it proliferative vascularization. Again, the aim is to prevent new blood vessels from growing. Okay, now the rosy, or some others might have early glaucoma. And there are two types, the open angle, and then the angle closure, and narrow angle glaucoma. Let's talk about open angle, which is the more common. What are the risk factors? The intraocular pressure is high. The normal is about 20, but there are certain special types of open angle glaucoma. Even if the pressures are normal, we call them low tension or normotensive glaucoma. These are unfortunately very common among Filipinos compared to whites. And, African racial heritage, advanced age, of course, and the greatest risk for glaucoma is family history. Okay, diabetes, hypertension, and myopia. Okay, the lens does not have blood vessels, so to nourish the lens, the eye produces a liquid like water. It's called aqueous. It's produced in this structure called the ciliary body. It passes through the pupil and drains into this structure called the meshwork. Just like dreno, like drain in our plumbing system. Okay, through the pupillary chamber. okay, drains here in this area, this meshwork. In primary open-angle glaucoma, the main problem is there's increased resistance of the meshwork. Parang nagbara yung drain. So the eye produces fluid constantly, but it does not drain, so the pressure builds up. Okay. How do you diagnose open-angle glaucoma? Of course, the eye pressure is the most important one. But we rarely diagnose glaucoma just on the basis of the elevated pressures. Okay, we take a look at the retina. Okay, there's some disease of the optic neuropathy, which is characteristic of glaucomatous nerve damage. As you say, the pressure builds up like a balloon. If there's a weak spot in balloon, that weak spot bulges out. In the eye, this is the weakest part of the eye, where the nerve enters the retina. That's the weakest part. Okay, this is a normal looking retina on fundus examination. Because of the build-up, the pressures, this bulges out, okay, and produces a cap. And the edge of the cap presses on the nerves, okay, and damages the nerves. So you diagnose it with field changes. Unfortunately, once field changes are noted, the disease is quite advanced. So the aim is to be able to detect glaucoma in the early stages, because once there's damage, unfortunately, is irreversible. Okay, this is the normal visual field. This is the blind spot. Where the nerve enters the retina, since there are no photoreceptors or rods and cones, that area is blind. So this is a typical glaucomatous field defects, normally in the periphery, okay, in paracentral, and then this is what's called a nasal step. Okay, what are the treatment goals for glaucoma? Is really to halt the field loss, okay, and to prevent further optic nerve damage, and use of medications to lower the eye pressures. There are many, many different types of drops. There's these alpha blockers, beta blockers, then prostaglandins, then lumican and tramatan. Okay, what are the mechanisms? Okay, well, some of the drops reduce the production of aqueous. Like in a plumbing, you want to turn off the faucet a little bit so that there's less water coming out. And the other drops increase the drainage of the meshwork. Baka barado yung meshwork like in plumbing. So, but there's some drops that both in combination. So in certain instances where most of the time they try one drop first. It doesn't control, it is not controlled. We use two different drops. And in certain instances, even 3 kinds of drops. Okay, in uncontrolled, if it's not still controlled, then laser is done, okay, to make openings on the trabecular meshwork. Sometimes surgery is done to make a bypass from the meshwork to the conjunctiva. And also there are some like pumps that are used to be inserted in the eye so that it drains outside the eye, outside is clear. Okay. Now we talk about the more serious one, which is fortunately rarer than the open angle, but it's again, it's more common among Filipinos compared to whites. Kasi it's not that because we are singkit, it's just because that the eyeball is smaller in among Asians than mga puti. So this is the iris, and this is the cornea. As you can see, there's a wide angle between the two, and this is where it drains. Again, fluid is produced here, okay, passes through the pupil and drains here at the meshwork. In some patients, because the lens swells, it pushes the iris towards the cornea and blocks the drainage. So the eye produces fluid, but there's no place to go. So the pressure builds up all of a sudden and causes what we call angle closure glaucoma. Okay, and the insusceptible cataractous lens because it swells and pushes the iris towards the cornea and blocks the drainage. Okay. So, and what are the risk factors common as we get older? Asian groups, especially Filipinos, and those who are heteropic females. Okay. So there's an instrument it works like a periscope because normally we cannot see this structure. Okay. So we have to use like a periscope to be able to see through. Okay. In this case, this is the periscope. Then you can see the angle. And this is the meshwork as we see it through the instrument. Okay. In narrow angles, okay, then if you again use the gonioscope, okay, can you see the difference? This is the open angle. You can see the structure, the architecture of the meshwork, but this is the close angle. You don't see those anymore. Okay. So what are the symptoms of angle closure? It usually happens very, very suddenly. Severe pain, blurred vision. The patient sees halos around lights. Okay, swelling of the cornea. This conjunctival injection, the conjunctiva becomes red. The cornea becomes hazy. And the pupil is mid-dilated. And it's an emergency. Okay, you have to be able to remember this. If you're taking this type of medications, Elavil, Antiber, Alipiem, Paxil, it can dilate the pupil. The problem is most angle closures happen at night because at night the pupils dilate naturally. And also these medications, you take them at night, then the pupils dilated, you can get an angle closure. And also patients, then you buy this over the counter, Vicin and Nafcon A. These drops can also dilate the pupils, can provoke an acute attack. Okay, so what do we do with angle closures glaucoma? So we make a hole on the iris. Okay, again, looking at this, clear. Okay, it's black here. So you make a hole here so that it bypasses. So you make a hole on the iris here, okay? So the fluid goes there. Fortunately now, you could use a laser to make a hole. During our residency at PGH, we have to open the eye and make a hole. It's so difficult to convince a patient, as I said, we diagnose it's a narrow angle, then we advise them to have an iridectomy. It's so difficult to convince a patient without symptoms that we're going to open the eye. Now, with the laser, it's much, much easier to convince a patient to have an opening of the iris to prevent an angle closure. Okay, I don't know how many of you have these mosquitoes flying around, and sometimes you think that it's like a mosquito, you try to catch it, and this is because, as we told, there's a gel that fills out the cavity of the eye. As we get older, it degenerates. Can we see these black spots moving around? Okay, this gel is attached in certain parts of the retina, here near the optic nerve, and here at the periphery. And as we get older, this gel contracts, okay, and detaches from the retina. And when it detaches, we experience flashing lights. So flashing lights is a symptom of the gel being detached from the retina. Okay, so it becomes what we call a posterior vitreous detachment. Sometimes the detachment is so strong, and it pulls the retina with it and makes a hole and causes a detached retina. Again, this is a serious problem, and hopefully what are the conclusions now? There's decreased vision with age. Some common eye conditions affect people over 50. Many conditions are preventable or treatable. And you want to improve and maintain visual function. And most important is coordination between your primary care and your ophthalmologist. And then whoop it up. We're not getting any younger. And a little bit of history. Rizal trained in Heidelberg. And they say that he went into ophthalmology because the mother was developing cataracts. He operated on his mother in the right eye in Hong Kong. Rizal practiced in Hong Kong for a while, and it was very, very successful. So when he was exiled in Dapitan, mother wanted to have the other eye operated on. The operation was successful. During that time, the patients had to be sandbagged. Sandbags are placed because the stitches were not being used. So the patients have to lie down for about 5 days. But the mother was so excited, jumped out of the bed, and the wound opened, and all the contents of the eyeball came out. So the eye became blind on the second eye. Okay, so this is the plaque of the eye clinic where I also trained. It says Dr. Jose Rizal, Philippine National Hero, practice ophthalmology from February until August for 6 months. And in 6 months, he was an expert duelist with sabers. In 6 months, he spoke perfect German, and didn't find a Frau, so he didn't get a girlfriend in Heidelberg. So I was in Heidelberg for 2 years. My German was fluent enough, but not as perfect as Dr. Rizal. Okay. And during that time, this is what the surgery looks like. The whole lens is removed. Whereas now, he may just make a small incision. And this is said after the successful cataract surgery, you see our grandparents with very, very thick glasses. Okay. So another bit of history, you can tell how old I am. I assisted in the cataract surgery of Emilio Aguinaldo. Emilio Aguinaldo was 94 years old. He was operated by our chairman. I was the senior resident. I assisted him during the surgery. He died in the same year. So, and that's it. And I'm ready for questions.
Sure. Thank you very much, Dr. Sunga. We have a bunch of questions here. I would like to remind everyone to use your Dropbox for some of your questions. So the first question we got is from Jesse Wolgamoti. In this time of information technology, plus the Zoom boom during COVID, folks are spending more and more time in front of their computers. I heard that blue light protection glasses can be used. Is there any evidence on its efficacy? What other recommendations would you have to reduce eye strain, especially for seniors?
The only thing that they have done research things, they've used different screens, large screens, distancing. But the only thing that they found in so many research papers is to have rest periods between long sessions, and also blinking a lot. You put a your what do you call this? Stick up papers and yellow papers, and put a large note there, blink. So it's more of the blinking, so that the tears lubricate the cornea. Okay, there's
Okay.
Some blue lights, unfortunately, because the blue light has shorter wavelengths, they have higher energy. It can damage the eye more worse. Why is the sky blue? It's because the water drops absorb the blue light more. The blue light have shorter wavelengths that they are absorbed by the water droplets in the atmosphere. That's why the sky is blue, because of the shorter wavelengths.
Okay, thank you, Dr. Sunga. Another question is, how should I best monitor my eye health?
Well, the most important is to see an ophthalmologist, not me. But just really to if there's a family history, especially if there's a family of macular degeneration, these are inherited diseases, macular glaucoma. So,
a follow-up question. So you mentioned about an ophthalmologist. When would I decide to go as an ophthalmologist as opposed to an optometrist?
No, an optometrist they're good in measuring eyeglasses, but ophthalmologist is more experienced in looking at diseases.
Okay. So should I consider eyeglasses versus contact lenses?
No, the only advantage of contact lens for most, especially women, is cosmetic. Even though the newer contact lenses are, most of the time there are no problems, but the thing, there still are foreign particles in the eye, especially those who like wearing masks. There are those who wear their contact lenses at night, even though they're contact lenses that are, as I said, okay for, approved for sleeping. I don't advise them because there's still foreign bodies in the eye and still can go, especially contact lenses, soft lenses, soft lenses to stay soft, it has to absorb a lot of water. And as we get older, we don't produce that sufficient tears anymore. So late in the afternoon, the contact lenses become hard. They can cause small scratches on your cornea. But as I said, but most contact lenses are well tolerated. But you just
Okay.
have to use a lot of lubricating drops. Okay.
Okay. During allergy season, what would you consider as the best eye drop?
No, they're over the counter. They're mast cell inhibitors, Saditor or something. Then if they're really bad, a low dose of steroids can be used. But the most important, most likely, if they're really bad, to see an allergist, whether see what you are allergic to. And unfortunately, sometimes they have to make skin tests with 50 to 100 patches. And the serious thing that you could do is you can buy this, or a primary care physician prescribes these steroids. They help, but in certain individuals, we call them steroid there's responders. It can cause glaucoma without the patient knowing it, just by the use of steroids for a few days. So before you use steroids, you should check with your glaucoma, with your ophthalmologist. And also drops, avoid drops that says to remove red eyes, because they can provoke narrow angle glaucoma. And so as much as possible, we advise patients not to use Bicin or Nacon or anything that says for red eyes.
Okay. So what are some of the things I could do normally to take care of my eyesight?
Yeah, as I say, just good hygiene. Okay, like as I said, the people, probably, especially, I don't know if you're over 40 or over 50, many eye diseases in the elderly, like hypertension, can cause problems in the eye. Diabetes can cause problems in the eye. So if you're 40, you should have, or 50, an annual visit, at least once a year.
Okay. So briefly, are eye examinations expensive? Roughly, how much are we looking at?
Cost-wise?
Correct.
Yeah, unfortunately, Medicare now says if you visit an eye doctor and they do a refraction, then the doctor charges you. Medicare does not reimburse you for refraction. And the refraction for most clinics is about $60. And for most patients, elderly, and most of the time, the Medicare cares for it. Pays for it. As I said, that there's so many eye diseases that are preventable, and also because of so many systemic conditions can also involve the eye. That an annual visit, but if you have a family history, then you see more frequently.
Okay. Now we have last two questions. I have this question coming from Junjun Villarreal. Are certain glasses, such as Enchroma, effective for color deficiency?
No, they tried. There are many types of color deficiencies. The most frequent are the red-green color deficiencies. Unfortunately, just by experience, they would know whether the wool is green or whether the wool is red. The main problem, if the two wools are together, he will not be able to distinguish which wool is present. But just by experience, if you show him a green wool or a green plate, he said that this is green, because all his life he knows this is green. There in certain monocrats, the monochromatic individuals. These are patients with only one. There are three types of cones: a red cone, a green cone, and a blue cone. Okay, in colorblind individuals, most of the time you don't have red cones or you don't have green cones, so you are red, green, blind. Deficient. There are certain individuals who have only one cone. These are patients, they're almost like albinos, and then you see the eyes moving like an nystagmus. They have tried dark colored glasses in these individuals. Also, among those buffs, much what they call World War I, II buffs, you can see the submarines before they emerge up. The room is dark. The control room is dark, except for red light. Okay, the red light does not stimulate the retina as bad as the blue light. So when they come out of the submarine at night, they are dark adapted.
Okay.
So you can see.
The last question, what are some things I could do for a young child with vision problems?
The most important is to be seen regularly by a pediatric ophthalmologist. Okay, so because there's so many, the child has like a motility problem, squint problems, strabismus problems. Many of these could be corrected. So there's some.
Thank you very much, Dr. Sunga. Now let's hear a brief announcement or message from the president of the University of the Philippines Alumni Association of the DC, Virginia, Maryland. Let's give a big round of applause to Ms. Jessie Walgamotti.
Thank you.
No worries, I don't need an applause. Thank you so much to everybody who is here right now and who joined us for this very informative webinar. Thank you so much, Dr. Sunga, for all that information. Who knew there were so many eye diseases and illnesses? So according to Shakespeare, the eyes are the windows to our soul. So it's easy to take our eyesight for granted. But vision loss can be a debilitating illness. So let's take care of our beautiful eyes. Thank you so much, everyone, for joining us.
Thank you. And I would like to take this opportunity to make some announcements of upcoming webinars. One scheduled on August 12, Accessibility and Aging in Place by Mariela T. Zuniga. And on August 19, Staying in Control of Your Bladder as You Age Gracefully by Dr. Modesto Rivera. August 20, I believe there's an update on COVID, what you need to know more about COVID, what's going on, what's new. And lastly, on August 25, What Can I Do to Reduce My Risk for Alzheimer's Disease by Dr. Patrick F. Reyes. With that, I would like to thank everyone for joining us. And this ends this session. Thank you very much and have a nice night.
Okay, thank you.
Let's
Bye-bye.
applaud for Dr. Sunga. Thank you.
Okay,
Thank you.